Very good evening to you all. It's indeed a pleasure and a privilege to have you all join back for this session today on neonatal resuscitation update and implications for practice. Before we proceed for this presentation, just few announcements. Henceforward, all our sessions will start at 8:30 in the evening. The ID remains the same, the user password remains the same, except day after, that is on Sunday, we have a special master class on endocrinology, which will be hosted by Dr. Vaman Khadilkar, and he will be sharing with us the entire neonatal endocrine spectrum. And this special class will be held between 5 to 7 p.m. So just keep that in mind that on Sunday, that's an exception, but by and large, the entire proceedings henceforward would be at 8:30 p.m. Today, another change that has taken place is that all of you videos have been blocked. So you would be only seeing the speaker, and if you have any questions, you would be putting them into the chat so we can have their discussion and interaction at the end of the session. Yesterday's presentation will be shared by email or on WhatsApp to all the participants. However, the recording of which was not possible, but we will be sharing the PowerPoint. So let's get going on today's presentation. Well, the story begins in the delivery room as you are called to attend the delivery of a primary which is about to take place. And as you reach, you find that the baby has established cry, the cord is cut, and the baby is brought to you. You examine the baby, give vitamin K, counsel about feeding, and you think your job is over. And this is what happens in majority of the cases, that we would find that no resuscitation would be required in almost 90% of the babies that you would be attending in the delivery room. But what major error has taken place in this case study? Well, we have forgotten that there are two key vital steps that need to be addressed and that need to be practiced. And these two steps are A, delayed cord clamping, and B, early skin-to-skin contact. And these two vital steps, which are simple, effective, low-cost, evidence-based strategies, have immense benefits, both short-term and long-term. And there is no reason why for vigorous babies or those babies who are well at birth, we should not be practicing these two important steps. We under-recognize their importance, we underappreciate their importance, and therefore a strong plea that henceforward all well babies be undergoing these two important steps of resuscitation, that is delayed cord clamping and early skin-to-skin contact. The ILCOR guidelines which came strongly recommended use of delayed cord clamping for at least 30 to 60 seconds in infants not requiring resuscitation. What it means is that in majority of the babies who have established spontaneous respiration and cry, you would be having masterly inactivity. You would be doing nothing for the next 1 minute, what is also called as timed cord clamping. What is equally important is as you practice this step of resuscitation, prior to arrival of the baby, we must have a clear understanding with the obstetrician as to who would be holding the baby, where would the baby be placed, how would the cord clamping take place. However, in certain situations where the baby has not established spontaneous respiration, you would be not practicing this step. As of now, the evidence also is not clear when it comes to multiple gestation babies, IUGR babies, those babies who have abnormal Doppler or those with abnormal placentation. But there is no reason why timed or delayed cord clamping is not a regular feature of to be practiced for all our well babies who are otherwise vigorous at birth. What else has to be done as this step of resuscitation is carried out? And this involves that as you wait for the baby, put the baby or nurse the baby on the mother's abdomen, and what is called as early skin to skin contact. And this is practicable for all babies beyond 30 weeks of gestation. And this is also a good way by which you would be able to maintain the baby's temperature by just covering the baby with a piece of cloth. And today we do know that hypothermia per se is an independent risk factor for death and or morbidity. And therefore, in all well newborns, we must practice delayed cord clamping and early skin to skin contact. Well, what is the current evidence and what is new in cord clamping which has come? This is a systematic review which got published, which compared delayed cord clamping with early umbilical cord clamping in preterm infants. We do know the short-term and long-term benefits which have been well established. What this systematic review added was that delayed cord clamping beyond 1 minute in preterms also reduces the hospital mortality to a tune of about 30%. And what is interesting to note was that the same size effect was found in the subgroup of 996 infants who were about less than 28 weeks of gestation. And therefore, this systematic review reinforces the need to perform delayed cord clamping for both term and preterm babies, for the benefits are immense. And this is a very practical, doable, and has huge implications in low-income country. What else is new in cord clamping? Well, there has been a lot of interest in milking of the cord. And again, this systematic review, which came recently, advocated that though it reduces the need for packed red blood cell transfusions, it did not improve the clinical outcomes. In fact, there was increased risk of severe intraventricular hemorrhage in such babies in whom the milking of the cord was practiced. So today, the standard of care remains that delayed cord clamping is a well-established step, but when it comes to cord milking for both term and preterms, it would not be what you can say a standard step, but would be done only if you are undergoing a research protocol. What else needs to happen in the delivery room in addition to these two steps which must happen? As you reach the delivery room, you must be able to identify, is it a high-risk pregnancy, by asking 4 focused questions. And once you know that this is a high-risk pregnancy, what it tells you is you need to gear up. You need more people. You need a team of people who would help you out, and you would be able to define the roles and responsibilities. What also it means is that you would do an equipment checklist, simply because as you have a high-risk pregnancy, you would anticipate a prolonged resuscitation. And during this time, you would want everything to work in a smooth, well-oiled fashion. Use of equipment checklist today, again, has been one of the bottlenecks. And therefore, the checklist should be today a part and parcel of the delivery room. Excuse me. Why are we so much concerned about being prepared? Up to half of the newborns who require resuscitation have no identifiable risk factors prior to birth. And the key point, therefore, is failing to prepare is preparing to fail. Let me repeat, failing to prepare is preparing to fail. And therefore, we must ensure that as and when we enter the delivery room, the birth of a newborn is a potential medical emergency. Let's move to the second scenario. This is the primee who has difficult labor and has been found to have meconium stained liquor. What is the plan? We realize that a meconium strain like a baby is a high risk pregnancy. We must perform an equipment checklist prior to the baby, and we must anticipate problems. We have roles and responsibilities which have been identified prior to the arrival of the baby. And most important, we must have a personnel who has intubation skills ready there in the delivery room. What does the evidence tells us? Today, there is insufficient evidence to suggest routine use of intubation for suctioning meconium in non-vigorous babies. And the emphasis has shifted on initiating ventilation in the first minute of life. So as the baby is born, you find the baby has meconium stained liquor and is not breathing. You cut the cord, get the baby under the radiant warmer. You position the baby. You do a quick oropharyngeal suction, stimulate the baby, and reposition to find whether the baby is breathing or not. Since the baby is not breathing or is having gasping respiration, you would initiate with positive pressure ventilation. As you initiate and give first 5 to 10 test breaths, you look for chest movements and you look for rise in heart rate. Obviously, if these are not there, you would do the ventilation corrective measure. You would ventilate with the mouth open and you would reposition the airway. Still, if you find there is no chest movement and there is no rise in the heart rate, you would move to the next ventilation corrective measure, and that is suction and ventilation with the open mouth. So it is at this stage that you intubate the baby to clear the airway of suctioning. Voice, little cold also has precipitated. Can you hear me? Shall we continue? Okay, so during the course of meconium, during the course of management of the meconium stained liquor baby, you have two opportunities where you intubate. A, you intubate for suctioning to clear the airway of meconium, and B, you need to intubate to ensure that adequacy of ventilation takes place. So that is how the algorithm today would be for managing a newborn with meconium stained liquor would be like. So what has changed? The entire emphasis has been that ventilation should take a priority, and this should happen as early as possible, and this has given rise to the concept of first golden minute. What does it mean? It means that following birth of the baby who has not established spontaneous respiration or cry, you would initiate initial steps, and within the first 30 seconds of performing the initial steps, you would not delay initiation of ventilation beyond first minute of life. So what it means is the ventilation must begin within first minute of life. And it is with this philosophy in mind, the change took place in the management of meconium, where the priority has been given for clearing, establishing the effectiveness of ventilation rather than giving a priority to clearing the airway. And what does the latest evidence and update on meconium staining management tells us? This systematic review, which got just published, showed that when you compare the vigorous, non-vigorous infants who were intubated versus those who were not intubated, there is no difference in terms of survival and no difference in terms of neurodevelopmental impairment at 9 months of age. So the current guidelines will continue to reflect the present management of meconium stained liquor baby of giving a priority to ventilation rather than doing a routine suction to clear the airway in babies who are born without spontaneous respiration or cry at birth. So the bottom line remains that you would continue to flow with initial steps, bag and mask, and if need be, chest compression and or intubation. And as we talk about positive pressure ventilation, which is a key step of newborn resuscitation, we need to realize that there is a subtle difference between the three devices which are available to us: the self-inflating bag, the flow inflating bag, and the TP resuscitator. What we do know is you would need a flow of gas to operate the flow inflating bag and the TP resuscitator. What we do know is these two devices would be able to deliver PEEP and CPAP. And what we do know is they would be able to deliver free flow oxygen. However, the most commonly used resuscitation device is a self-inflating bag. And the reason is that it is easy to operate. However, what is common to all the devices is that the delivery of tidal volume is quite unknown, and a variable amount will be delivered irrespective of the pressures that are being generated. And there is today no evidence to suggest superiority or inferiority of one device over the other. What we do know is whatever device that you are more comfortable with and well versed with would work for you. There is a theoretical advantage of use of TP's resuscitator for preterm resuscitation simply because it is thought that prejudged pressures and oxygen will be less harmful to the immature lungs of the newborn. But for low resource settings, the use of self-inflating bag is a great, what you can say, simple tool to help save lives. The biggest mistake which happens with bag and mask ventilation is inability to achieve a seal. If you are going to use hold it at the rim, or if you are going to hold it along the circumference, it is very likely that you would end up with flow or what you can say leak at the mouth. So what is expected is that you should be applying firm pressure along the flat surface of the mask, what is called as the 2-point top hold way, which will achieve a tight seal. And this is a make or break when it comes to use of self-inflating bag, because a self-inflating bag will work well only if a good adequate seal has been achieved. And therefore, this is something which needs to be practiced and which can be learned by working on mannequins. As we continue to provide bag and mask ventilation, the single most reliable factor to assess the effectiveness is rising heart rate. But what we do realize is a rising heart rate does not tell you that you are hyperventilating the baby. And this is again a common error which takes place with provision of bag and mask ventilation, is the tendency to hyperventilate. And therefore, the bottom line remains that we should be able to ventilate at a rate of 40 to 60 per minute, and the mnemonic of breathe 2, 3, breathe 2, 3 would be able to achieve the desired goal. And learn to ventilate and not to hyperventilate is the message when it comes for bag and mask ventilation. We said the heart rate remains a critical factor in terms of assessing the response to resuscitation. And again, this systematic review, which came just a year back, looked at the techniques by which we looked at heart rate. One is by palpating the cord, the other is by means of auscultation, the other is by means of pulse oximetry, and the last but not the least is by means of use of ECG. Now, we do know that the reliability of palpating at the base of the umbilical cord is poor. We do know that when it comes to auscultation, we are good when it comes to bradycardia, but we would underestimate the heart rate if it is high. The pulse oximeter is much better compared to stethoscope, and the gold standard so far has been identified is ECG. What are the clinical implications of these? A, that if you are needing resuscitation, the fastest and quickest way to assess the heart rate is by means of palpating the umbilical cord. However, the more reliable and fastest way is by means of auscultation. As you go beyond bag and mask resuscitation, you would need the heart rate to be assessed by means of a pulse oximeter. And today, it is recommended that if you have reached a step of chest compression, you would rely on ECG for detecting the heart rate. So the utility of ECG is primarily when you have a prolonged resuscitation or when you have the need for chest compression, simply because the cardiac output is so low that it will hardly generate a impulse which will be detected either by the pulse oximeter or by means of auscultation. But the key point here is look at the time required for achieving or detecting the results. You would find that there is a huge time lag of 30 to 60 seconds when it comes to use of ECG, but when it comes to pulse oximeter, it will take anywhere from 60 to 126 seconds for assessing the heart rate. And therefore, with these due limitations in mind, what is the bottom line? A, pulse oximeter use is a narrow window for us to detect the heart rate, but its utility is more for detecting the oxygenation status. As soon as you enter bag and mask resuscitation, the good way to detect the heart rate would be by means of pulse oximeter. But the moment you enter into the stage where you start chest compressions, you would need to move out of pulse oximeter simply because the pulse oximeter will not be able to detect any impulse. And it is in such situations one would rely on ECG. Now, mind you, the evidence for ECG is very poor. Majority of the evidence for use of ECG for detecting heart rate is by an indirect extrapolation of data and never ever from what you can say resuscitation of newborns. And further, the time which is spent in applying the chest leads and getting the ECG signal and getting the skin prepared is a huge bottleneck. And we do know there is a time lag, but the utility is it will detect a heart rate when it is not clinically detectable. And there are reports in newborns of pulseless electrical activity where ECG picks up the heartbeats, but otherwise clinically you feel that the newborn has no heart rate. And the utility therefore remains of ECG only when there is a prolonged resuscitation or where you want to be 100% sure that there is no heart rate. And therefore we would make use of these options which are available to us of detecting the heart rate based on their due limitations. A dozen of new, what you can say, instruments have been developed in the form of plethysmograph, photo plethysmograph, an electronic smartwatch, Doppler ultrasound, digital stethoscope, and so on and so forth. But all of these still are in experimental phase. And as of now, we only have the three options that we just discussed about detecting the heart rate during newborn resuscitation. It is equally important that if we don't find the heart rate to rise as we initiate positive pressure ventilation, we must take corrective measures. And these are measures which take place in couplets. So you would do mask readjustment and reposition immediately one after the other, give 5 to 10 chest breaths, look for chest movements. If you don't get the chest movement, you would move to the next step of another couplet of suctioning the mouth, opening the mouth, and providing ventilation. Give 5 to 10 test breaths. And if you still find there is no chest movements, you would increase the pressure or consider intubating the baby. And these ventilation corrective measures are simply essential and need to be performed because unless and until your ventilation is guaranteed, you would continue to have the baby move into hypoxia, however good you may be in further steps of resuscitation. So the key point remains that ventilation is a key step of newborn resuscitation. B, the rise in heart rate tells us that our ventilation is effective. And C, if you don't find that the heart rate is rising, one would take corrective measures. As we ventilate, how much should the oxygenation be? And this is an update from ILCOR, which appeared this year and which is likely to get reflected in the new guidelines also, which suggests that if you ventilate, if you supplement oxygen to term or babies beyond 35 weeks of gestation, at the initiation of resuscitation, in terms of room air, there is a relative risk of short-term mortality, which is less in the room air oxygen group. What is also clear is there is huge harm of using 100% oxygen, which is known to increase the mortality. And therefore, the current recommendations remain that babies beyond 35 weeks of gestation and those who are term, you would initiate ventilation by means of use of room air. And the key points, therefore, we learned was that give an emphasis to establish ventilation in the first minute of life. Ensure that you get heart rate to increase as you initiate resuscitation. Be very aggressive in terms of use of ventilation corrective measures. And when it comes to meconium stained lacquer, you would not give priority to intubation, but you would give a priority to establish ventilation. So let's move to more complicated scenario, and this is a 28-weeker who is about to be delivered and the mother has PIH. So how would our preterm resuscitation be? As you enter the delivery room, you realize based on the 4 focus question that this is a high-risk pregnancy. You anticipate a difficult or prolonged resuscitation, so you identify personnels, you allot roles and responsibilities, you do an equipment checklist ensuring that the equipments are in order, and more so that they are of a smaller size, for we are anticipating a very preterm. And if time permits, we would counsel the parents. As you get ready, what else needs to be done? You must ensure that this is something which takes a huge priority, especially for preterms. We are all well aware when it comes to resuscitation that ABCD is the approach: airway, breathing, circulation, and drugs. But when it comes to newborns, and especially the preterm newborns, it is TABCD. That means thermal care takes a high priority, and however good you may be in ABCD, you would continue to fail, or you would not get the desired response if you are not able to maintain the temperature during the resuscitation. What do we do know? Majority of the babies, especially preterms, go on to develop hypothermia during resuscitation. We do know hypothermia is an independent risk factor, not only of morbidity, but mortality. And for every degree of temperature which is low below 36.5 degrees Celsius, the risk of mortality increases by at least 28%. What we do know is that there is a dose-response relationship between hypothermia and neonatal outcome in terms of morbidity and mortality. And therefore, hypothermia today is not because of lack of equipments, it is because of our ignorance. And therefore, every effort must be made to ensure that we give a warm welcome to this newborn, especially if it is a preterm newborn. So what should we do? Current evidence tells us that no single strategy is good. A combination of strategies would be required to maintain the temperature of this newborn in the delivery room. Provision of early skin-to-skin care, use of warmers, a plastic wrap, a head cap, ensuring that the room temperature is 26 to 28 degrees, use of thermal mattress if it is available. Multiple of these need to be performed, more so if we are dealing with a very preterm. And again, the philosophy of care remains the same. We would initiate, if the baby has not established spontaneous respiration, with the positive pressure ventilation within the first minute of life. But what is unique to preterm resuscitation is this ventilation needs to have PEEP in addition to PIP. The latest update, which again came from ILCOR about use of oxygen in babies less than 35 weeks of gestation, reaffirmed that the current practice of use of 21 to 30% of oxygen is reasonable to begin with when it comes to preterm resuscitation. And when we talk about non-invasive ventilation, or when we talk about use of provision of positive pressure ventilation to these babies, look at this when only the PIP is being delivered, and you would find that only the ventilation is taking place with the large airways with hardly any opening of the alveoli which is taking place. Now look at this, when we are now ventilating this preterm, in addition to the PIP, we have given PEEP, and you would soon find that the entire lungs gets recruited, and you are able to open up the alveoli, and therefore current evidence strongly advocates use of PEEP in addition to PIP for ventilating a preterm newborn. And for those preterms who have established spontaneous respiration and cry, but are having breathing difficulty, one would initiate only by means of CPAP. And we do know that this form of non-invasive respiratory support today is standard of care for all preterm births, and therefore the implications are twofold. A, when it comes to preterms, PEEP with PIP is the way ahead in terms of ventilation. And for those babies who have spontaneous breathing but have respiratory difficulty, we would support by means of CPAP. And these two videos clearly told us how much is the alveolar recruitment which takes place when we add that CPAP or the peak and expiratory pressure to our delivery of ventilation. What else? As we continue to ventilate, time would be some of the preterms would need intubation. Gone are the days when we would intubate by using this formula. What we have is the nasotragus length, which will decide the depth of insertion of the endotracheal tube, but the most reliable way to intubate is by means of use of gestation or a weight-based chart. And it would be desirable if we have these endotracheal tube size and the depth be displayed based on the gestation and the weight chart. What are unique things when it comes to chest compression? Two things only that need to be remembered. A, intubate the baby if you are going to start chest compressions. And B, start 100% oxygen. And as you are on chest compression, remember the only way by which you would assess the heart rate would be by means of an ECG monitor. However, the heart rate check during positive pressure ventilation was after every 30 seconds. However, when it comes to chest compressions, you would wait and assess the heart rate at the end of 60 seconds of ongoing coordinated chest compression with ventilation. The first drug we talked about in newborn resuscitation, many of us forget it, and this is oxygen. And we therefore must give a high priority of using oxygen in a judicious manner. What we do realize that some of the babies may not respond to our steps of resuscitation, and by means of a vascular access, either through umbilicus or by means of an intraosseous way, one would be able to do administered drugs. And routine use of volume expanders for babies not responding to resuscitation is not recommended. In fact, it would be more detrimental, and you would use volume expanders only if there are signs of shock or there is history of blood loss. So what does our preterm resuscitation look like? As you enter the delivery room, you anticipate, you prepare the personnel, get the equipments in order, lay down your priorities in terms of care, and ensure that as the baby is born, you would skip the initial steps by getting the baby under the plastic wrap. We know thermal combination strategies we would initiate. For those babies who don't breathe, we would initiate positive pressure ventilation with room air. We would consider use of PEEP while we ventilate. We would consider use of ECG for heart rate, and those babies who have spontaneous breathing, we would do CPAP. And last but not the least, do not leave the delivery room unless you document the temperature. Debriefing will help you become better next time. The entire focus so far as newborn resuscitation is always on knowledge and skills. We forget that two elements which make or break a newborn resuscitation, especially if it is prolonged or difficult, and that is teamwork and communication. So the workshops look at simulation as a way by which you would build up teamwork in which you would sharpen the skills of communication. So just having knowledge and skills is not enough to have resuscitation. You must work as a team. And what does team stands for? Together, everyone achieves more. So what have we learned? We have learned that the best practices based on available evidence is that for all babies who establish spontaneous breathing and cry at birth, we would initiate early skin-to-skin contact. We would practice delayed cord clamping. If the baby does not establish breathing following initial steps, we would ensure that ventilation begins within the first golden minute. The response to ventilation would be judged by rising heart rate. If we don't find a rising heart rate, we would take ventilation corrective measures. When it comes to preterm, use of PEEP is mandatory. We would use oxygen as a drug. And last but not the least, we will continue to practice the steps of resuscitation, incorporating the teamwork and communication principles. So that is how, in a brief, what you can say, nutshell, the entire newborn resuscitation based on the current evidence I have tried to share with you. And I would be happy to take your questions. Please do type down in the chat box.
Yeah, Rishi, thank you so much for such a wonderful elucidation on the newer aspects of neonatal resuscitation. There are some questions, and you can see them from the Q&A. Please answer, look at the questions, and maybe I'll read the questions. You can read, you can answer. There is one question: availability of neonatal ECG leads and difficulties fixing on the slippery skin and practical limitations.
Yeah. If you read that systematic review that I shared with you, the ECG works well only in two circumstances: prolonged resuscitation, or where you are not sure to consider discontinuing resuscitation. So for all practical purposes, the use of ECG as a, what you can say, primarily dictating our resuscitation is not much. Now, mind you, we also know that though it detects the heart rates the best, so far there is no evidence that tells us that your resuscitation practices based on that heart rate will help improve the neonatal outcomes. So with these two lacunae or drawbacks, we would use ECG with a pinch of salt.
But how do we attach? Because they are saying that it's slippery.
That is why we have to have one person who dries, cleans the surface, ensures that the ECG leads. So it's again one personal job who looks only at getting the ECG in order.
Which is superior by evidence between endotracheal versus umbilical vein? I think this is for and the adrenaline. Endotracheal, intraosseous UVC.
Okay, if we have the option of administering epinephrine, the best option would be to give by means of umbilical venous access. However, till the time you have, in gaining an umbilical venous access, you would administer by means of an endotracheal tube. Mind you, the dose is almost 10 times when you administer it through endotracheal tube compared to what otherwise would be by means of umbilical venous route, though the concentration would remain the same, 1 in 10,000. And the important thing is that though you have administered, say, an endotracheal epinephrine and you gain an IV access, you would consider this dose as null and void and immediately move to the umbilical venous access as your primary route for administration. Intraosseous is as good as intravenous when it comes to administration of any and every drug.
There are some more questions. How to give PEEP is TPs is possible. You can resist with TPs and give PEEP. There is one question from Kiran More from excellent job, Rishi. This is Kiran More. Just a question regarding resuscitation with intact cord during delayed cord clamping. Use of life start trolley. What is recommendation in Indian scenario?
Okay. There is growing body of evidence to suggest that you could resuscitate by means of an intact cord. And last year in the NeoCon, we had one gold medal presentation which took place about such an indigenous resuscitation trolley, which came from Chennai, where the study was performed. However, I have restricted myself only to standards of care and not at those which are what you can say upcoming strategies, because as of now, the data is not, or the evidence is not strongly in favor to support them as standard of care. What I have restricted myself is what can we do and continue to practice, which will make our strategies better and safer.
There is one question from Surendra Bisht. What is the importance of timekeeping?
Everything starts and ends with time. The timelines are very critical when it comes to newborn resuscitation. And the timelines are one, which starts at the time of birth. Now, the clock starts once the baby is delivered. The clock does not start once the baby's head is out or the shoulders are out. A. B. Your decision making of initiating positive pressure ventilation is in the first golden minute. Your decision making thereafter is at every 30 seconds as and when you continue to be on positive pressure ventilation. However, the timeline shifts over from 30 seconds to 60 seconds when you are on chest compressions. And once you are on chest compressions, you administer epinephrine, your timeline shifts to 3 to 5 minutes thereafter to administer the next dose of epinephrine. And lastly, the timeline ends when you have 10 minutes of a systole, despite ongoing all resuscitative efforts, when you are likely to say the chances of survival of this baby is futile. So it's very critical that everything is time bound, time based, time paced.
The other thing is, do you always intubate if chest during when you're starting chest compression?
It will be very difficult if you continue to provide positive pressure ventilation by means of bag and mask and continue with chest compressions. So the moment you decide that the baby is likely to need chest compressions, you would electively intubate. And for some reason it is not at the earliest, you would ensure, simply because however good you may be in terms of coordinating ventilation and chest compressions, we must ensure that the ventilation is appropriately performed and the ventilation is perfect, simply because the commonest cause of babies not responding to the steps of resuscitation is, unless proved otherwise, in 2/3 of cases, inadequate ventilation. So you must ensure, secure the airway, get onto the ventilation in the sense that you capture and are completely in control of ventilation. So that makes your ventilation and chest compressions as a good strategy.
There is one question that in preterms you said it is between 21 to 30%. So does it mean we start with 21% and go up to 30, or we start with 30?
No strong evidence. It just says, okay, the evidence does not tell us what is the good percentage to start oxygen for babies less than 32 weeks of gestation. So what we do know that if you start with higher oxygen, these babies are at risk for increased morbidity, if not mortality. And therefore, you would titrate oxygen based on the minute-specific oxygen chart and then move either up or down. We would start low and then move up. That is what we practice.
There's one more question. Between bag and mask, self-inflating bag and mask and flow and TPs, which one you prefer?
If it is a term newborn, for all practical purposes, your self-inflating bag works best simply because it is easily available. There's no issue of anything going wrong. The problem with T-piece resuscitator are twofold. A, that if you are especially going outbounds or going for delivery calls, that delivery room must have a T-piece resuscitator. The second thing is a T-piece resuscitator is good only if it has a good air oxygen supply, and that means that it must have a blender. If you don't have a blender and you want to run a T-piece on oxygen, it defeats the purpose. And when it comes to preterm resuscitation, as I said, there is a theoretical advantage of what you can say pre-decided delivery of PIP, PEEP, and FiO2, which gives it an edge. But the bottom line is, irrespective of whatever device which you use, whatever you are familiar with, and whatever your resources permit, choose the one.
So you said there is a very important differentiation between 35 weeks and above. Now, how do you differentiate between a 33 weeker and a 36 weeker immediately after birth when EDDs are not very sure?
The simple way would be to look at the posture of the baby. Now, the best way would be to know the EDD if it is available, because that would be the most correct way. If not the EDD, then the ultrasonographic gestation that has been defined. Our assessment of gestation in the delivery room is far from perfect. Time and again, studies have shown that a same baby, when is assessed by two different individuals, will come to a conclusion on two different, what you can say, gestational ages. And a simple clue is the baby beyond 34 weeks or is the baby less than 34 weeks? And if you have a flexion of the knee which is there, it tells you the baby has crossed 34 weeks of gestation.
The other thing is, as you already said that when you're using T-piece, we have to use a blender. And again, during transport, it is always good to have a blender around with T-piece. Definitely, we won't advocate using T-piece with 100% oxygen. Am I true?
Correct. That is the biggest drawback. There is a blender blunder when it comes to our scenario, simply because blenders is one of the missing equipments in the delivery room.
So there is one, Dr. Rohit, if the baby is limp at birth and did not cry, can we do initial steps with intact cord over the mother's abdomen? And if the baby starts crying, do delayed cord clamping? And is this more physiological?
Well, yes, some have looked at it of performing the initial steps, and in fact, even provision of bag and mask ventilation on the mother's abdomen with the cord intact. And these studies originated from India also. And unless you are part and parcel of the research protocol, I would suggest you would continue to resuscitate with the cord intact. But for all practical purposes, for standard of care, it would demand that as soon as the baby is born and you find that the baby is lame, you would cut the cord, get the baby under the resuscitation corner, and initiate resuscitation.
Okay, there are many more questions. In case of a blender has to be accompanied with compressor, yeah, I think at this point of time you don't have any easy methods of giving air oxygen mixture, but very soon we might get a blender without air compressor. So these are being manufactured, and I'm sure very soon this will come into the market. Dr. Vijay wanted to show video of ECG application. Sir, would you like to take over? Should I make you the panelist so that you can show the video, Dr. Vijay? I'm taking over the host, Rishi.
Yeah, okay.
Dr. Vijay, do you want to show? Yeah, Kedar has a question, and Subramaniam Shastri, they have shown, they have, okay, just a minute. So before we end, Rishi, can you stop sharing your screen?
Okay.
Anyway, Dr. Vijay is saying that he doesn't have a video, but if there is any video he would like to see. So does anybody have a video of ECG attachment? Kiran, do you have one? So before I end, I want to again reiterate that on tomorrow it is 8:30 p.m. and tomorrow we are going to talk about neonatal shock. This is going to be presented by Dr. Mohit Saini. He would talk on shock management using guided by the echo or functional echo, and the ID, that is the webinar ID and the webinar password, is same as today. But we have a special webinar on Sunday, which is shown on the screen here. All of you can take a photo shot of this this PowerPoint, which is projected now. So the webinar ID and webinar password are different for Sunday webinar, but all other webinars, it is the same one which you use today.
And the speaker is Dr. Vaman Khadilkar.
Okay. Yeah. No, that on Sunday it is Dr. Vaman. Yeah.
Yeah. On Sunday, we have Dr. Vaman Khadilkar who will take a master class on newborn endocrine problems.
Yes, there were issues with logging in today from yesterday's ID. No, we did not use yesterday's because yesterday allowed only 100 participants. So we had to increase the participant to 500, and that is the ID has changed. But from today onwards, the ID will remain same for the next 15 days, except for Sunday. Sunday ID is different because it's on a different timing. Dr. Rima's question was this. So today's webinar is recorded. I will try to see if I can put it on the YouTube, and maybe we will share the link of the YouTube when we start tomorrow our session. So thank you everyone.
Yeah, thanks a lot.